Then is amenorrhea, disorders of the menstruation. Differential diagnosis of amenorrhea is with secondary sexual development, without secondary sexual development. In the secondary sexual development, it is divided into two: normal breast and pelvic development, normal breast, abnormal uterine development, hypothyroidism, hyperprolactinemia, and PCOS, hypothalamic dysfunction, and normal breast but abnormal uterine. So it could be Mullerian dysgenesis, uterovaginal septum, and imperforated hymen. So in the without secondary sexual development, it could be like high FSH and low FSH. High FSH is basically hypergonadotropin hypogonadism, and low FSH is hypogonadotropin hypogonadism. So hypergonadotropin hypogonadism, like high FSH, is could be because of Turner, XO, and normal XX chromosomes like 46XS and 46XY. Low FSH is basically constitutional delay, like rare in girls, congenital abnormalities, isolated GnRH deficiencies, pituitary failure, and Kallmann syndrome, head injury, pituitary adenoma, etc., acquired endocrine disorders like type 1 diabetes mellitus, pituitary tumor, and secondary disorders, IBD, juvenile rheumatoid arthritis, chronic infections, etc., functional hypothalamic amenorrhea, Asherman syndrome, uterine defect. Then most common causes of the primary amenorrhea: Mullerian agenesis, abnormal sex chromosomes, Turner syndrome, functional hypothalamic amenorrhea. Then comes is basically differential diagnosis of the secondary amenorrhea with hyperandrogenism and without hyperandrogenism. With hyperandrogenism is basically PCOS, autonomous hyperandrogenism, androgen secretion independent of HPO axis, ovarian tumor and hypertrichosis, and adrenal androgen secreting tumor. Late onset or the mild congenital adrenal hyperplasia, which is very rare. Without hyperandrogenism, hypergonadotropin hypogonadism, primary ovarian insufficiency, high FSH, and low estradiol. Idiopathic autoimmune type 1 diabetes mellitus, autoimmune thyroid disease, Addison disease, iatrogenic cyclophosphamide drug, and radiations. Then comes is basically hyperprolactinemia and endocrinopathies, like most common is hyper and hypothyroidism, hypogonadotropin hypogonadotropin hypogonadism, low FSH, pituitary compression or destruction, pituitary adenoma, craniopharyngioma, lymphocytic hypophysitis, infiltration, head injury, Sheehan syndrome, and functional hypothalamic amenorrhea, often related to the stress exercise, excessive exercise, or anorexia. So then is functional hypothalamic amenorrhea is the secondary most common cause of the is the most common cause of secondary amenorrhea. Amenorrhea is basically we take history and physical examination, then we see if it's primary or it is secondary. If it's primary, then we look for the secondary sexual characteristics. If it's yes, then we go for karyotype and we check it's XX or XY. If it's XX, then it's imperforated hymen, transverse vaginal septum, cervical agenesis, and Mullerian agenesis. Then it's basically XY, then we do androgen insensitivity syndrome. Secondary sexual characteristics uske, like she has a problem, then we go for karyotyping, then we check for XX and XY. XX is basically imperforated hymen, transverse vaginal septum, cervical agenesis, Mullerian agenesis. Then it's XY is basically androgen insensitivity syndrome. In secondary sexual characteristics, if there is no problem, then we go for FSH and LH. High, it's basically caused by gonadal agenesis and dysgenesis. Basically secondary sexual characteristics problem is there. So if secondary sexual characteristics are present, then we go for karyotype. If secondary sexual characteristics are not present, then we go for FSH and LH. Then if it's high, then it is hypergonadotropin, and if it's low, then it is hypogonadotropin. High is basically gonadal agenesis, dysgenesis, and low is basically constitutional delay, HPO axis abnormality. Then secondary amenorrhea beta HCG is basically negative and positive. If it's positive, then it's pregnancy, and if it's negative, is basically prolactin. Then comes if prolactin level is abnormal. Prolactin level is high, like normal is less than 20. If it's more than 20, then it's a problem. And CT head if it's more than 100. TSH to screen for hypothyroidism. Prolactin normal, then we go for progesterone challenge and withdrawal bleed. If there is a progesterone challenge we done, and then there is a withdrawal bleed and there is no withdrawal bleed. If there is no withdrawal bleed, then it's basically primary ovarian insufficiency, uterine septum uterine defect, and Asherman syndrome or HPO axis dysfunction. And then there is a withdrawal bleed, then we go for LH and FSH. If it's high, then it's PCOS, like hyperandrogenism. And if it's low or normal, then we go for HPO axis dysfunction, MRI hypothalamus, pituitary measure other pituitary hormones, and maybe like primary what was that, functional hypothalamic amenorrhea caused by weight loss, excessive exercise, and systemic disease. Then comes this investigation. Then we do the same things, all of them together, like beta hcg, hormonal workup, tsh, prolactin, fsh, lh, androgens, estradiol, progesterone challenge to assess for the estrogen status, medroxyprogesterone 10 mg daily for 10 to 14 days, any uterine bleed within 2 to 7 days after completion of the provera is considered to be positive withdrawal bleed, and withdrawal bleed suggests that presence of adequate estrogen to thicken the endometrium. Thus, the withdrawal bleed of the progesterone results in the bleeding. If no bleeding occurs, this may be secondary to the inadequate progesterone, like hypoandrogenism or excessive androgen, or progesterone like residualization, pregnancy, obstructive cause, or maybe cervical stenosis, or secondary causes like uterine adhesions. Karyotypic basically indicated if primary ovarian insufficiency or absent puberty, then we do karyotyping. Ultrasound to confirm like normal anatomy and identify PCOS. Prolactinoma symptoms, galactorrhea is basically visual changes and headache. Then comes the treatment. Treatment is according to the cause. If it's androgen sensitivity syndrome and Mullerian agenesis, we go for the psychological counseling, and then we go for the gonadal resection in the androgen insensitivity syndrome after puberty and creation of the new vagina with dilation. In Mullerian age and dysgenesis, MRKH syndrome, then we go for psychological counseling, and in that we do creation of the neo vagina with a dilation diagnostics study to confirm normal urinary system and spine. Then comes this imperforated hymen. We do surgical management, transverse vaginal septum. Then comes the surgical management, cervical agenesis, suppression, and ultimately hysterectomy. Primary amenorrhea is basically no menses by the age 13 in the absence of the secondary sexual characteristics, or no means by the age of 15 with the secondary sexual characteristics, or no menses after thelarchy. So secondary amenorrhea is basically no menses for the more than 6 months or the 3 cycles after documentation of menarche. Then is basically secondary amenorrhea. Secondary amenorrhea is basically caused by HPO axis dysfunction, like identify the cause and then treat that one. Then combine OCPs to give decreased risk of osteoporosis and maintain normal vaginal and the breast development, not proven to work. Hyperprolactinemia, MRI or CT to rule out lesion if no demonstrable cause lesions by MRI. Bromocriptine, cabergoline if fertility desired, and combine OCPs if no fertility desired. Then we can give like bromocriptine and everything. So demonstrable lesions by the MRI, we do surgical management. PCOS, there is written in the PCOS section. Then comes the primary ovarian insufficiency, screen for the diabetes mellitus, hypothyroidism, hypoparathyroidism, hypocortisolism. Hormonal therapy with the estrogen and progesterone to decrease risk of osteoporosis can use OCPs after induction of the puberty. Uterine defect, basically evaluation with the hysterosalpingography or the sonohistography. Asherman syndrome, we do excision of the synechiae. Secondary amenorrhea is the pregnancy until proven otherwise. Then comes abnormal uterine bleeding. Abnormal uterine bleeding is divided into regular and irregular. Regular is basically heavy or intermenstrual. Intermenstrual is basically caused by polyps, abnormal uterine polyp, and heavy is basically caused by adenomyosis, leiomyoma, coagulopathy, and endometriosis. Then is irregular. Irregular is basically unpredictable and basically abnormal uterine bleeding. So it is basically either ovulatory or maybe malignancy. Approach, we have to ask the questions about ascertaining frequency, regularity of the menses, duration, volume of the flow, impact on the quality of the life, timing, it is irregular or is it irregular. On the basis of that, we will decide what is the cause. Cycle to cycle variability, like less than 20 days, or irregular is basically more than 20 days. Is it heavy, like more than 80 cc, or is more than 8 days? Bleeding that significantly affect quality of life. Is it structural, like basically palm? And then is it non-structural, basically coin. So postmenopausal bleeding is menstrual endometrial cancer until proven otherwise. Abnormal uterine bleeding is change in the frequency, duration, or amount of menstrual flow that affect the quality of life. Then comes the abnormal uterine bleeding etiologies and investigation and management. Polyps, adenomyosis, leiomyoma, malignancy, and hyperplasia. Polyps is basically we have to do investigation is basically transvaginal ultrasound in all of them. Polyps, adenomyosis, leiomyoma, malignancy, we do transvaginal ultrasound. So if we find out that this is a transvaginal ultrasound, there is a polyp, then we can also do saline infusion sonohysterography to see the position of it, and in the management we can do polypectomy according to the triage, like based on the symptoms, polyp size, histopathology, and patient age. So if it's a very small, we don't have to do anything. Then comes is adenomyosis, transvaginal sonography, and MRI. Then it's written in the adenomyosis. Leiomyoma is submucosal and others. So transvaginal sonography, saline infusion sonohysterography, and diagnostic hysteroscopy and MRI. Then comes is basically malignancy and hyperplasia, and transvaginal sonography, endometrial biopsy for all the women more than 40 with abnormal uterine bleeding. We have to check for the endometrial hyperplasia. For women less than 40 with the persistent abnormal uterine bleeding or endometrial cancer, risk factors dependent on the diagnosis. Non-structural is basically coagulopathy, ovulatory dysfunctions, endometrial, iatrogenic, or not yet classified. Coagulopathy is basically CBC, coagulation profile, especially in the adolescent, von Willebrand factor, ristocetin cofactor, and factor 7. Dependent on the diagnosis, hormonal modulation, OCPs, Mirena IUS, endometrial ablation. Ovulatory is basically like we have to do blood work, CBC, beta HCG, ferritin, prolactin, FSH, LH, androgen, free testosterone, DHEA, progesterone, 17 hydroxyprogesterone, TSH, free T4, and pelvic ultrasound. Then we do endometrial biopsy, tranexamic acid, hormonal modulation, Mirena IUS, and endometrial ablation. Iatrogenic transvaginal ultrasound, rule out forgotten IUD, and maybe we have to check for OCPs or HRT use and review medications, especially neuroleptic use, and remove offending agent. Not yet classified is basically. Some of them is basically not yet classified. Then comes the treatment: resuscitate the patient if hemodynamically unstable, treat underlying cause if the anatomical lesions and the systemic disease has been ruled out, consider abnormal uterine bleeding. Then what is the basic treatment? What we do is basically medical. Mild abnormal uterine bleeding, we do NSAIDs, antifibrinolytic like cyclocapron at the time of the menses, and combined hormonal contraceptives, progesterone on the first 10 to 14 days of every month for every 3 months if abnormal uterine bleeding is basically caused by ovarian. Then we can give is basically Mirena IUD, and then for correction of the anemia we can give iron. Acute severe abnormal uterine bleeding, replace fluid losses, consider administration. We give estrogen along with the gravel. If a woman comes with the severe abnormal uterine bleeding, what we give first is basically estrogen. So estrogen is given, or antifibrinolytic we can give along with it. Tapering OCPs regime, and then taper to like one pill from the 7 day to one pill with the gravel, and or taper off to one tablet like one daily. So after or maintain patient on the monophasic OCPs for the next several months, or consider alternative medical treatment. Medical is basically high dose progesterones and danazole, GnRH agonist, allopurinol acetate, and then we can do is surgically polypectomy, myomectomy, endometrial ablation if finished childbearing, and repeat procedure can be required if the symptoms reoccur, especially if less than 40 years. Hysterectomy, definitive treatment. So this is the basic treatment if a patient come with the abnormal uterine bleeding. Like in the mild we give NSAIDs, antifibrinolytics, CHC, progesterone, Mirena IUS, and anemia. And then in the severe we start with the estrogen, and then we can also switch to like high dose progesterone, danazole, and GnRH agonist, allopurinol acetate. Then comes the dysmenorrhea. Dysmenorrhea is basically, what is the definition? Recurrent crampy lower abdominal pain during menses in the absence of the demonstrable disease. Secondary is basically pain during menses that can be attributable to an underlying disorder like endometriosis, adenomyosis, and fibroids. Then comes the etiology, like primary, secondary is basically caused by endometriosis, adenomyosis, polyps, abnormalities like if the of the uterine, like maybe there is a horn, and leiomyoma, synechiae present in the intrauterus, ovarian cyst, cervical stenosis, imperforated hymen, transvaginal septum, transverse vaginal septum, PID, IUD, which is basically copper causing dysmenorrhea, and foreign body. Then comes the primary and secondary. Primary is basically features recurrent crampy lower abdominal pain that occurs during menses in the absence of the demonstrable disease. Secondary comes is basically similar features as the primary, but with an underlying disorder that can account for the symptoms such as endometriosis, adenomyosis, or uterine fibroid. Sign and symptoms basically colicky pain in abdomen, radiating to the lower back, labia, and the inner thighs, and beginning hours before onset of the bleeding and persisting for hours or days. Associated symptoms basically nausea, vomiting, altered bowel habits, headache, fatigue, prostaglandin associated. Then secondary dysmenorrhea is basically same symptoms as the primary dysmenorrhea, associated dyspareunia, and abnormal bleeding and infertility. Diagnosis: how we made the diagnosis of the primary, basically it is associated with the dyspareunia, abnormal bleeding, infertility, signs of like this secondary dysmenorrhea, menorrhea, and rule out underlying pathology and confirm cyclical nature of the pain. Then comes pelvic examination, which is basically not required in the primary one, indicated for the patients not cross responding to the therapy, with the signs of the pelvic ultrasound. And the treatment is basically regular exercise, local heat, and NSAID should be started before the onset of the pain, and then combined hormone contraceptives we can be given. Extended use is suppressed like ovulation and reduced menstrual flow. Then comes in the diagnosis of the secondary dysmenorrhea. Bimanual exam, we start from the examination because we are thinking of underlying pathology, so you have to start from the bimanual examination, like uterine or the antinaxial tenderness, fixed uterine retroflexion, uterosacral nodularity, pelvic mass or enlarged irregular uterus. Findings are rare in the woman less than 20 years. Ultrasound, laparoscopy, or hysteroscopy may be necessary to establish the diagnosis. Vaginal and the cervical culture may be required. And then what we do is basically treat underlying cause. Then comes the endometriosis. Endometriosis is the presence of the endometrial tissue like glands and the stroma outside the uterine cavity, like chronic condition resolving along with the menopause. Etiology is basically not fully understood and maybe some other mechanism going on, like Samson's therapy and NK and all these. Then comes etiology, epidemiology. Mean age is basically 25 to 30. Regression after the menopause. Clean differential diagnosis is basically chronic PID, acute salpingitis, hemorrhagic corpus luteum, benign and the malignant ovarian neoplasm, and ectopic pregnancy. 4Ds of the endometriosis basically dysmenorrhea, dyspareunia, dyschexia, and dysuria. In the dyspareunia is basically the endometriosis in cul-de-sac or uterosacral ligament, dyschexia, uterosacral ligament and cul-de-sac and rectosigmoid attachment, and in the dysuria it's basically bladder involvement. Then is the risk factors. It's 7 to 10 times in the family history. In the first degree relative, obstruction anomalies in the genital tract resolves with the treatment of anomaly. Then is basically nulliparity and the age more than 25 years. Sites of injury occurrence is basically more in like 60% in the ovarians, where is caused like chocolate cyst and broad ligament, vesicoureteral fold, and cul-de-sac, uterosacral ligament, rectosigmoid colon, appendix rarely may occur in the abdomen, pelvis, lungs, and diaphragm. Clinical features basically may be asymptomatic and can occur with the one of the three presentations. Pain is basically menstrual symptoms, cyclical symptoms due to the due to growth and bleeding of the ectopic endometrium, usually precede menses and continue throughout and after flow. Secondary dysmenorrhea, sacral back pain with the menses. Pain may eventually become chronic and worsening, and perimenstrually deep dyspareunia. Bladder and the bowel dysfunction like frequency, dysuria, hematuria, diarrhea, constipation, hematochexia, dyschexia, and due to deeply filtrating disease. Then is basically infertility, like 30 to 40% with endometriosis will be infertile, and 50 to 30% which who are infertile have the endometriosis. So there is a mass that is basically present in the ovaries, like or maybe somewhere else. So ovarian mass can be present with any of the above symptoms or maybe asymptomatic. Pelvic examination is like tender nodularity or the of the uterine ligament and cul-de-sac felt on the uterosacral vaginal exam, fixed retroversion of the uterus and formed and the fixed adnexal mass, which is basically endometrioma, and the endometriotic cyst in compressing ovary. Then comes the diagnosis. What is basically, it is basically definitive diagnosis can be based on the direct visualization of the lesion, typically of the endometriosis at laparoscopy. So the gold standard is laparoscopy. Biopsy can be done and histological exam of the specimen, 2 or more of the endometrial epithelium like glands, stroma, hemosiderin, lateral macrophages. Then comes the laparoscopy. What is we find in the laparoscopy is basically mulberry spots Endometrioma, we find the chocolate cyst, powder burn, and early white lesions and the clear blebs and peritoneal pockets. Okay, then comes the CA-125, which can be elevated in the endometriosis and should not be used as a diagnostic test. On the side, endometriosis take home is basically in the suggestive of history, even with a negative exam, should be considered as adequate for the presumptive diagnosis. So only the history is more than enough for making a diagnosis. Pelvic pain that is not primary dysmenorrhea should be considered endometriosis until proven otherwise. So if there is a pelvic pain that is not primary, so it is endometriosis. And then medical management is the mainstay of endometriosis. If the patient comes with a history of the suspected endometriosis, what we go is we can do combined hormonal contraceptive therapy. Then we can give progesterone alone, like IM, oral, subcutaneous, any one could be fine. Failure of the first line therapy, we go for laparoscopic, either laparoscopic or either we can go for the second line, GnRH analog with the add back. Then comes is basically progesterone IUS, and if both of them uh, both of them used for the failure of the surgical or the medical therapy. Consider diagnostic additional testing if both of them doesn't work, chronic pain management, and the multidisciplinary support. Treatment is basically surgical confirmation of the disease is not required prior to the starting of any medical therapy. So we can start for asymptomatic endometriosis does not require treatment, and management depends on the certainty of the diagnosis, severity of the symptoms, extent of the disease, and desire for the future fertility. Impact of gastrointestinal and genitourinary symptoms, intestinal obstruction. Medicals we give NSAID in first line is basically cyclical or continuous estrogen progesterone, and then we can also give progesterone or Mirena IUS, or basically oral denogest. Second line is GnRH, or we can give danazol. GnRH is given like a leuprolide, which is basically caused like menopause like symptoms like hot flushes, genital dryness, and libido. So we have to do add back therapy of the progesterone or estrogen to prevent the BMD and reduce vasomotor side effects. And danazol, which is a big weak androgens which can cause weight gains and the fluid retention, age, hirsutism, and acne, hirsutism, and voice changes. Then comes the surgical like conservative laparoscopy using laser, electrocautery, and laparotomy. Ablation, resection of the implants, lysis of adhesions, ovarian cystectomy of the endometriomas, and suggested hysterectomy, bilateral salpingo-oophorectomy. Best test to become pregnant is immediately after the conservative surgery. If the patient is not planning to become pregnant, post-operatively suppress suppress ovulation medically to prevent reoccurrence. So in the woman who wants to get pregnant, the best thing is we can do like myomectomy, lysis of adhesions. Then comes is basically adenomyosis. Adenomyosis is basically endometriosis interna. Usually, what happens is uterine wall may be diffusely involved, and like more than 35% found in 20 to 40% of hysterectomy specimen. Mean age is basically 40 to 50 years. Adenomyosis is like a histological finding in the asymptomatic patient. Adenomyosis is basically adhesions of the area of the endometrial gland and stroma into the myometrium. So what happens is clinical features often asymptomatic, heavy menstrual bleeding, secondary dysmenorrhea, pelvic discomfort, dyspareunia, dyschexia, uterus symmetrically bulky and usually less than 14 centimeter. Halban signs tender, softened uterus on premenstrual bimanual exam. Clinical diagnosis, we can do ultrasound or MRI can be helpful, and can endometrial sampling to rule out other pathology. Final diagnosis of adenomyosis is based on the pathological finding but predictably identified on MRI. Then what we do is basically iron supplementation for anemia, analgesics, NSAIDs, Mirena IUS, CHC, medroxyprogesterone, limited efficacy for the limited evidence of efficacy for the medroxyprogesterone. Then we can also give like GnRH agonist and danazol 100 to 200 per oral daily. And then for the surgical, we can do hysterectomy treatment of the choice in the women who have completed child bearing.